So I'm going to focus today on size measurements in this context because I think that's something as pathologists we all find challenging. So I think regardless of the context you work in, if you're reporting breast pathology now, you'll be seeing a significant number of neoadjuvant chemotherapy specimens, and they can be quite a challenge. So it's become routine management of women with high-risk disease, particularly triple-negative breast cancer and HER2-positive breast cancer. So we've kind of moved to this setting now where we can see the response of the tumour to treatment. We can potentially tailor subsequent local, regional and systemic therapy. In particular, patients who have a complete response, we know they've got a relatively good prognosis and we may be able to de-escalate further treatment. And patients who do not have a pathological complete response will now often get further adjuvant treatment. So for example, the Catherine study with the introduction of TDM1 in patients that have residual disease. So this concept now of response to neoadjuvant chemotherapy acting as a biomarker, particularly for those HER2 positive and triple negative patients with high risk disease. So this paper was published just over a year ago now by the AJCC Breast T&M group led by David Winchester. And this brought forward the idea of, can we look at response to neoadjuvant chemotherapy and use it to impact prognostic breast cancer staging? So in the 8th edition, there was the introduction of the prognostic staging system. This was for the AJCC. For those of you in Europe and the UK, the UICC did not adopt the prognostic staging system. And the idea here is it incorporated tumour grade, ER, PR, HER2 status, as well as anatomic extent of disease to put patients into different prognostic groups modified by biology. However, at this point in time, it wasn't possible to incorporate neoadjuvant specimens. This was purely for cases in the adjuvant setting. So what the AJCC group did was they went back and got data from the National Cancer Database from 2010 to 2018, so just over 140,000 patients who'd received neoadjuvant chemotherapy. It looked at pre-treatment grade and receptor status. So this is the original pre-treatment core biopsy, what the tumour grade, ER, PR and HER2 was. They looked at the baseline clinical staging, so tumour size and nodal status derived from imaging and clinical examination, and they then compared that to the final pathological size, so our YPT and YPN classifications. And it was put into 3 broad categories. So no response. These were patients where the clinical T and CN was the same, or else the YPT was higher than the original clinical staging. So that was either YPT or YPN being higher than the original staging or both being the same. And that had an 85% survival. There was the partial response group, and this group also had residual invasive disease. However, either the YPT stage or the YPN stage was lower than that original clinical staging, and neither of those were allowed to be higher because that would put them in the no response group. And finally, we've got the pathological complete response group. So YPT naught, they were allowed to have in situ disease, and YPN naught, and you can see that group has 96% survival compared to 87.6 for the partial responders and 85.5 for the no responders. And if you look at the tables in the paper, what we end up with, so the clinical stage 1 group, you can see virtually all of them in the complete response stage 1A, so very low. I think there's one group that was 1B, but excellent staging for complete response. And of course, at this low level, we've also got fairly low stage for the no response and partial response. And interestingly, I think because of low numbers, in some of these categories, the partial responders actually seem to fall into a higher stage group than the no response group. If we go to clinical stage 2, you can see again, PCR, all stage 1A, and the no response has a worse outcome than the partial responders, with some of these falling into stage 2 and stage 3B, in particular for the HER2 positive and triple negative groups. And finally, if we look at those that are stage 3, initially, again, we've got a bit of a change here. So for the higher grades and the HER2 positive and triple negatives, a lot of those are still falling into the 1A and 1B group. Interestingly, it's the grade 1s that fell into a slightly higher stage sometimes in the complete responders. Whereas in contrast, the no response or partial response, these had very high stage disease if post-chemotherapy, if they didn't show a complete response, and that was higher for the grade 3s and for the triple negative and HER2 positives. And what we can see is we've got lovely separation of those curves, which is what the TNM would like to see across the different stages. We've only got 4 stage groupings really for the PCR group because of numbers. So what that shows is that the initial clinical stage is important, even if patients have a pathological complete response. And conversely, PCR is a very, very important marker of prognosis, regardless of stage, grade, or biological subtype. For the patients with residual disease, advanced stage, high grade, and triple negative status were all associated with worse survival outcomes and higher final post-chemotherapy prognostic stage, whereas interestingly in the PCR patients, grade 3 seemed to be associated with improved survival, and it was actually the lower grade that was associated with slightly worse survival outcomes. And again, there were very low numbers in that group, and it's probably suggesting that some of the patients in that group, that the chemotherapy wasn't really having an impact. So this data is being collected by the National Cancer Database. I've been told I'm allowed to say it is ready for incorporation into TNM9. Obviously, TNM9 hasn't been released yet, and there may be some tweaks before the final release. And in the paper, they're talking about, this is still fairly crude groups with, no response versus partial response. We know in some contexts there can be, for example, the stage may be the same, the YPT may be the same as the clinical T, but you may have a marked reduction in cellularity indicating response, although you haven't seen a change in staging. So in the future, it may be possible to refine this by incorporating something like the residual cancer burden into staging. And that has now been incorporated into the CAP dataset as an optional item. It is one of the mandatory items in the ICCR dataset. And if you're in the US, the RCB data will start to be collected by the National Cancer Database. So this brings up how measuring size post-neoadjuvant chemotherapy is going to become even more important because it's potentially going to impact staging post-chemotherapy. So we all know this can be much more difficult post-chemotherapy. It's a combination of size and cellularity is the best marker of response. And what happened within total tumour size, so in the 6th edition of the TNM, and this is also the system in the residual cancer burden, you measured the total size, tumour cell to tumour cell, so not the extent of the background fibrosis, the extent of the area occupied by the residual invasive cancer, but you also included fibrosis in between. So if it had a patchy pattern of response, you still measured the total size, including those areas of fibrosis. Whereas in the 7th and 8th edition of the TNM, and this is both AJCC and UICC, they started bringing in this concept that it was the largest contiguous focus of residual tumour cells, and you don't include that intervening fibrosis. And we're going to talk a little bit about the challenges that's introduced, because obviously that brings in a huge element of interpretation. And then in the 8th edition, the additional change was if you have this patchy pattern with multiple foci, you then start to use the M modifier to treat this like multifocal disease, even though this was originally a single tumour that's just had a patchy pattern of response. And this is a lovely paper from Benjamin Calhoun's group where they looked at the difference in stage using the criteria, and you can see you've got quite significant downstaging in a large number of cases, switching between that TNM7 compared to, or TNM8 compared to the earlier classification systems. So it does make a difference in the number of patients that get assigned to those earlier staging groups. So how do we measure size post-neoadjuvant chemotherapy? We've got two main patterns of response. So that concentric shrinking pattern, that's relatively easy for us as pathologists. I kind of think of that's like when the cancer's a balloon and it's just shrunk down and you've just got a single residual focus of invasive tumour. So again, you measure the residual invasive cancer only. That's tumour cell to tumour cell. If you've got a whole lot of background fibrosis and macrophages and those sorts of things, you don't measure the background reaction, you just measure that residual invasive disease. So that setting's relatively straightforward. That tends to be the pattern of response for ER negative, HER2 positive, and for triple negative cancers. The group that's a little bit more difficult is where we get this scattered pattern of response. So here's an example. We've got that original footprint, and post-chemotherapy, that footprint is preserved, but we've just got these little scattered single foci rather than a large, continuous tumour, and that's what that looked like with these scattered foci. So what do you measure in this setting? So in the old days, or for the RCB, it's relatively straightforward. You still go tumour cell to tumour cell with the fibrosis in between, whereas now we've got the TNM staging saying it's that largest single contiguous focus. And I must admit, my reports, I'll give a descriptive report, and I include both the largest measurement of that single focus, but I'll also make a comment on the total size of disease that's distributed. So for example, that might be 16 millimeters, but if the whole tumor is involving multiple slices extending over 52 millimeters, I will also give that measurement, and that would be your measurement for calculating the residual cancer burden. So there's this lovely paper recently in Modern Pathology by Quackenbos et al. And what they did was they sent a survey around to a whole lot of pathologists in different countries to find out how exactly they were handling this. And this just shows, pathologists were asked to rate the difficulty for measuring both tumour and the nodes. And you can see we've got some in that 9 to 10, so highly confident group. But a lot of people are saying, actually, we find this really difficult to measure size in this context. So this was 208 pathologists for over 35 countries around the world. So they all said they were using the TNM definitions, but I won't spend too much on this. How do you define a contiguous focus? Is it tumour cells touching each other? That was 13%. Limited amount of stroma with regression. The majority was saying limited amount of stroma, irrespective of whether or not there was regression or not. And then some of them were including all the intervening stroma. So you can see quite a big difference in how different pathologists are interpreting that definition of a continuous tumour cluster. And again, limited amount of stroma, less than 5 millimeters. So in our normal adjuvant setting, we talk about that 5 millimeter rule, whereas if you've got tumour less than 5 millimeters apart, you still measure that as a single lesion. And it looks like most pathologists are not using that 5 millimeter rule, but what they're doing is they're looking at the way the tumour cells are distributed across the area. So just to show some of the examples from the paper, so you can see here this example. We've got normal breast tissue, we've got tumour cells scattered individually across that, and the vast majority of pathologists are measuring that as a single lesion. And that's the same if there's no normal breast tissue, but we've just got those background sort of fibrotic changes. Just to say, very few people are measuring the fibrosis. So in this context, the measurement should always be tumour cell to tumour cell, not including fibrosis if that extends beyond the background residual cancer. And here's another, if this was in clumps rather than evenly dispersed single cells. And again, if those clumps of cells are relatively evenly distributed, people are tending to measure that all as a single tumour rather than just measure the largest individual group. So it's looking at the way things are distributed. Is it fairly even? And again, it's not measuring that extent beyond the invasive cancer. So fairly good concordance when we've got this relatively even pattern, whether it's a single cell pattern, as you'd possibly see in a lobular cancer in the normal setting or adjuvant setting, or else whether they're occurring as clumps of tumour cells, but relatively evenly spread across the tumour bed area. The part where it starts to become difficult is when you've got what they call an uneven distribution. So again, got a big group here, big group here. The majority of people tend to be calling that a contiguous cluster and measuring that as the largest size, with a significant group still including the whole thing with the fibrosis. So that would be your RCB measurement. And I guess strictly using the TNM rules, D2 is your TNM measurement. And again, not many people, you shouldn't be measuring the fibrosis. It's just tumour cell to tumour cell. But as you start to throw groups in between, you start to get a shift with how people are measuring it. So even though it's still discrete clumps that are not really evenly distributed, we're starting to get less and less concordance as to how you measure that and whether you treat that as a single tumour or whether you look at the largest group and say, actually, that's the largest contiguous cluster. So the take-home message is this is not easy. There's a lot of difference in interpretation between pathologists. And again, with that clumping pattern, it's the same thing. We've got different sort of groupings of clumps of cells. And when they're all relatively far apart, there tends to be greater agreement, and people will measure that single cluster or the majority. But as you start to throw more and more clusters in between, it becomes less consensus as to what you define as the largest contiguous group, although the minority of people just take that one single cluster of cells that's touching. And again, just showing the same thing. So the advice they offer in this page, and this is also mirrored in the guidance given in the ICCR and what I tend to tell people in my lectures. Number one, I always think about the growth pattern in the adjuvant setting, particularly for unusual tumours like lobular cancer. If this was a lobular cancer in the adjuvant setting, how would I be measuring this? Because sometimes you get that slightly cannonball sort of growth pattern. So really we shouldn't be measuring it differently. The measurements are tumour cell to tumour cell. Do not measure stroma if that's extending outside the residual area of the invasive tumour. Even distribution, so taking a step back, are the cells relatively evenly scattered across the tumour bed with consistent spacing? And in that setting, possibly measure the full area covered by the tumour cells, including that sort of fibrosis in between. Whereas an uneven distribution, if you're getting clustering of tumour cells in certain areas, if there's variable spacing between those groups of cells, then you measure the largest single group of residual cancer cells, including the stroma within that group, as you would normally. So in a tubular cancer, you don't measure the largest tubule, you measure the area with the tumour cells and the stroma. And to me, it's not really clear, is there a role for the 5 millimetre rule post-chemotherapy? I must confess, I don't tend to use it. I do look at that growth pattern more. So I tried to pull out some cases to illustrate this just from sort of our routine practice. So this is a relatively easy one. We haven't had a fantastic response here. We've still got a single tumour, measuring it tumour cell to tumour cell. And in this context, you're not just going to look at cells that are touching each other. You're going to include that background stroma as part of the tumour as you would in the adjuvant context. This one is a lobular. So again, that's the whole area. This is just on a single slide. I think this actually involved multiple slices. So we ended up getting our largest dimension from the number of slices. But again, fairly typical growth pattern for a lobular carcinoma. Some areas more cellular, other areas slightly less cellular, but that was spread pretty much over the entire area of the tumour. So to me, that's what my maximum tumour dimension is going to be, the same way I would measure a lobular carcinoma in the adjuvant setting. And again, just another example of a lobular carcinoma showing that growth pattern, and I would measure that the same way I would measure a lobular carcinoma. So I'm not just going to look at the largest row, I'm going to look at the way it's spread out and take that whole area involved by the cords of invasive lobular cells. Again, this is a relatively easy one. So this was a big tumour bed and we just had 2 residual clusters of cells. In this case, it was exactly almost 5 millimeters apart, but you've got one tiny cluster of cells here, another cluster, this was the larger one, 110 microns. So to me, I would treat those separately. In my report, I said there was, residual invasive, excellent response with residual invasive disease comprising 2 clusters of cells. The larger cluster was 0.1 millimeters and the total area was 5 millimeters. But I staged that as residual microinvasive disease. Oh, sorry, it's just over a millimeter, isn't it, as a T1A. Here's another one. This was one that was presented at the MDT this morning. So again, we've got these clusters of cells or clumps of cells that are widely spread, and this was present in multiple slices from this patient. So in this case, this is, to me, is the largest single grouping, because this is a relatively uneven distribution. So that group was just under 5 millimeters, and the total area was over 5 centimeters when we added all the slices together, or we used lots of mega cassettes. In this one mega cassette, that was 52 millimeters. So in the report, we give a descriptive report with scattered residual foci of invasive cancer. The largest single cluster measured 5 millimeters, and the total extent of disease was 52 millimeters. So this is a T1A. This is not a T3 tumour because it was present as residual scattered foci. Okay, another one. So this is again getting a little bit trickier. So we've got this more solid clump of cells here. Then we've got these sort of smaller clusters more unevenly distributed in the background. So 27 millimeters, tumour cell to tumour cell. We're not sort of going fibrosis beyond. But if we took the largest, I guess, more continuous or clumped group of cells, that's 10 millimeters, that more solid focus. So I guess strictly speaking, this is where it becomes interesting, because I think if you were to use that 5 millimeter rule, all of these smaller cell groups are less than 5 millimeters apart. I think the way this was measured at the time it was reported was using that 27 millimeters. So there's a huge amount of variation here. I don't think there necessarily is the right or wrong. It's using your judgment. So at the time, we reported that as 27 millimeters, but I think using the guidance from that paper, you could argue that's probably the largest contiguous group is that 10 millimeter group, and then you've got these more irregular sort of scattered foci in the background, giving that total size of 27 millimeters. And finally, another one, again, this had very scattered small foci, quite widely apart. So you can see these individual cells. These individual cells are not particularly evenly dispersed. They're sort of at quite irregular intervals, although we've got this one group that was sort of a bit more in continuity, and that was measuring 0.4 millimeters. So again, total area 27 millimeters, but our largest continuous focus is probably only 0.4 millimeters. So again, I would put that into a descriptive report. I always include the cellularity, as you would for calculating the residual cancer burden. Our oncologists like to know that cellularity as well. So 27 is going to be your RCB measurement plus whatever this sort of measurement here is. But for your TNM staging, I think in this, because of the uneven way these cells are distributed, the largest single cluster is 0.4 millimeters. And so I've got another group again. This one's a very similar pattern, just these scattered single cells, some of them grouped together, some of them more widely spaced. And again, at the time we reported this, I think it was felt because there was sort of a cells present across the whole bed that was measured as 16 millimeters. But you could argue with semantics, you know, these are almost isolated cells because they're not particularly evenly distributed. I must admit, in this context, if you've got a single size, sort of a single area on the slide, I do still tend to measure that as a single lesion, even though you could argue these cells are not particularly evenly distributed. The other interesting scenario is mucinous carcinoma. So what can happen in a mucinous carcinoma is you can get complete response in the invasive tumour, but you have the mucin left behind. So in the adjuvant setting, and we had a bit of a discussion, I don't know if any of you were also on the masterclass a couple of weeks ago, is if in the adjuvant setting, I tend to include the mucin in my maximum tumour dimension. But in the neoadjuvant context, again, I'm going to go tumour cell to tumour cell. So you've got this big area of mucin in the middle, maybe just an occasional rare scattered cell. We've got this group here where the cells seem to be slightly more concentrated, but the whole area that they're spread over is 31 millimeters. So again, I think the way this was reported at the time, this was given a stage T2 and measured at 31 millimeters. But you could argue, if you look at the way these cells are distributed, perhaps a measurement of 13 millimeters would have been more appropriate. So huge challenges. I think we need better guidelines on how to do this. I think that paper is a lovely paper. It sort of gives a first step in terms of how to approach this. But, you know, at the moment, there's a lack of consensus and a lack of uniformity in the way that we're staging these tumours. And that's partly because of the ambiguity in the language that's used within the TNM guidelines. So that's the measurements in the tumour. Lymph nodes, this should be much easier, but we've kind of got a similar situation here. So just the way we assess them in general, the node should be embedded in its entirety. We look for areas of fibrosis, and there should be a comment on if there's evidence of previous involvement with response. We don't routinely do additional levels in immunohistochemistry, and the guidelines don't recommend doing these. But if I've got this pattern with fibrosis, I've got a fairly low threshold for doing cytokeratins just to make sure there aren't any residual tumour cells hiding in there. So these examples are all pretty obvious. That node's almost completely replaced by fibrosis, so it's pretty obvious, you know, I think that used to be metastasis. Similarly here, we've got that sort of slightly myxoid reacting looking stroma. We've got that wedge shape, and that looks like that used to be a metastasis, but we've had a response. And here's another one. So we'll talk about TADS in a second, or targeted axillary dissection, where they clip the positive node and then remove that afterwards. And again, that's pretty obvious. There's fibrosis all the way through that node. Here again, this is another node from the same patient. I think that's sort of wedge-shaped. It's quite reactive looking. I would also say that there was evidence of response in that particular node. But here's a case I reported today, and I looked at the first node, and there was this little bit of fibrosis here, and to me it's quite common to see sclerosis like this in the adjuvant setting as well. So as time's gone on, I have become a bit stricter in the criteria I apply when I say whether or not there's been fibrosis in the nodes indicating response. But then I got to this second node, and it's like, okay, it's much more focal, it's close to the capsule, and you could argue perhaps I've been a little bit inconsistent. I said there were two nodes present, both negative for metastasis. one of them containing residual fibrosis. But it's probably getting, I did stop and think for a while as to whether or not to call that or to just disregard it. So again, quite subjective, that concept of commenting on whether or not there's fibrosis with regression in the lymph nodes. Sometimes it's very easy, and now I require something, you know, with that wedge shape, often the stroma looking a little bit more reactive, things like histiocytes, pigmented macrophages, because I think you just get you can quite commonly see a little bit of sclerosis in nodes even outside the chemotherapy setting. No, measuring metastasis. So before the latest TNM, it was relatively easy. It was that same concept, metastatic tumour cell to tumour cell within the node, including the intervening fibrosis. Then the last TNM, it became a little bit more complicated. And in the lymph node as well, we're talking about this concept of the largest contiguous focus. So what do we mean by contiguous focus? And if you look at the wording in the TNM, it's quite literal. They do mean tumour cells that are touching each other. But if you've got a tubular cancer and a metastasis in the node, you don't measure the size of the largest tubule, which is the tumour cells touching each other. You measure the entire size, including the intervening stroma. So again, I think you need to take a step back and think, okay, outside of the chemotherapy setting, how would I measure this deposit? And again, the RCB is tumour cell to tumour cell, with that including the fibrosis. But you don't, if the fibrosis, if I were to change this circle and the fibrosis was extending out here, you don't measure the fibrosis extending beyond the tumour cells. It is a tumour cell to tumour cell measurement. Okay, isolated tumour cells are a bit tricky. Difference in significance post-chemotherapy. This is residual treatment-resistant disease, and this is where it gets a bit inconsistent. So in the TNM, strictly speaking, it's YPN0. You've got that I classifier for the ITCs, but it's not classed as pathological complete response. So you've got YPN0, but it's not PCR. In the RC Path guidelines, it was called node positive, and residual cancer burden, you include those as positive nodes when you're doing your RCB classification. So if you've got 3 nodes with isolated tumour cells, what I do is I put the number as 3, and sometimes I might put in quite a low value for the size, because you're really just measuring the single tumour cell. So those of you who've seen me talk before will have seen this slide. I just think it's a lovely example of the challenges or the differences. So here we've got a clip. This was a TAD procedure where they got the targeted node. We've got this big area of fibrosis, obvious, very atypical looking cells lying within the fibrosis. But here's our cytokeratin. We've got these cells all touching each other, 0.15, so that would be isolated tumour cells. We've got this cluster that's a little bit closer together, that's 0.8, so do we call this a micrometastasis? Or if we use the old system, and this would be the measurement for the RCB, the 2 cells that are furthest apart is 2.5 millimetres. And that would be a macrometastasis. I must admit at the time, I think we split the difference and it was 0.8 millimetres. Now I'm going to go through what's happening because this is an area that's changing rapidly. So in the past, it didn't really matter because the recommendation, or in terms of patient management, I should say, it didn't really matter because the recommendation was post-chemotherapy, patients should have an axillary clearance even if there are isolated tumour cells present. This is another example, again, a case that I presented in the MDT a couple of days ago. So here's our node. I think that cluster's possibly a little bit easier to see. It was a lobular, so we've got mucin vacuoles. Are there possibly some cells with mucin vacuoles here? I think they're harder to see. And as always with lobular cancer, you do your cytokeratin, and there's a lot more cells than you expected. And I think here, this is not unique to neoadjuvant chemotherapy, it's the same challenge here. How do you measure this with that growth pattern of lobular cancer? Do you use the 200 cell cutoff and say that this is I think you'd at least call this a micromet? Do you look at the largest group of cells? Would you take a measurement with the whole lot? And I think way my colleague interpreted contiguous was this group was all relatively in continuity, and that was called a micrometastasis, but not always straightforward. So again, this paper looked at the way lymph nodes are handled. So if it's a sentinel node, about 60% of pathologists reported they looked at multiple sections compared to about a third looking at a single H&E, with roughly just over a third doing routine cytokeratins. Non-sentinel nodes, 2/3 looking at a single H&E, and again a subset doing routine cytokeratins. The problems they highlighted is harmonizing the new YPN definition with the RCB methodology and this concept of whether or not to include fibrosis and what is the definition of a tumor cell cluster or a contiguous group of tumor cells. So there's that same question again with respect to the lymph nodes. So slightly different, sort of definitely not using the 5 millimeter rule here. It's the distribution of cells, but again, 18% the tumor cells have to be touching to each other for that tumor cluster. And again, the most popular definition is a limited amount. What is a limited amount of intervening stroma? They would measure that as a single group. And again, it's looking at the distribution. If there's an uneven distribution, do you measure the foci and use the largest? In even distribution, do you measure it as one focus? And the vast majority tend to use both those options in terms of how to define it in this setting. So again, think about the growth pattern, think about what this metastasis would look like in the adjuvant setting. Measurements at tumor cell to tumor cell, so this is a repeat. You do not measure stroma or fibrosis extending beyond that residual invasive metastatic tumor. Even distribution, measure the full extent covered by tumor cells encompassing all tumor cell clusters and the intervening fibrosis. So if it's relatively even, you'd measure that as a single focus. Uneven distribution, when you've got variable spacing, largest single group of residual cancer cells. However, you probably would include the stroma within that cluster. So that's not what the wording in the TNM is. The TNM talks about tumor cells touching each other. So why is this all important? Well, the hot topic at the moment is all about de-escalation of auxiliary therapy. I don't know about your surgeons. Our surgeons seem to want to do less and less operating. They don't want to go back for margins, and they're wanting to do auxiliary surgery in fewer and fewer patients. So standard of care now, I think, is moving towards sentinel lymph node and targeted auxiliary dissection for a selected group of patients that were initially node positive. So those patients that were clinically node negative at the start have been getting sentinel lymph nodes. We know that's safe, and there's now an increasing body of evidence that doing the same thing for patients that were proven node positive works. But the question is moving beyond that, and if patients have positive nodes post-chemotherapy, do they all still need an auxiliary node dissection, or are there patients that we can omit that? And I think what's happened is, although the Z11 or Z11 criteria was specifically for the adjuvant setting, some surgeons have started applying that in the neoadjuvant chemotherapy setting as well. So the practice has kind of raced ahead without necessarily there being the evidence. So this was the original study that looked at the role of targeted auxiliary dissection, or SLN, for patients that were node positive. And what they found was overall the false negative rate was 12.6%. This was better for dual mapping, And if 3 or more nodes were removed, it was 9%, which was the 10% cutoff for it being acceptable. So sentinel lymph node with removal of 3 or more nodes seemed to give an acceptable false and negative rate. So here are some of the main studies. So again, that Z1071 trial, I think, was the landmark trial. That was the overall false negative rate, although in some of the subset analyses it was less than 10%. NSABP B27 was an earlier study. That was 10.7%. And I think the other big study was the SNFNAC, 13% false negative rate, but if you did immunohistochemistry and identified nodes with ITCs, that fell to 8%. So all these studies looking at potential role for sentinel node post-chemotherapy. There was a subset in this study where they put in a clip and did what was called a targeted axillary dissection. So that's removing the sentinel nodes with the clipped node. So in 3/4 of cases, the clip was in one of the sentinel nodes, and in that subset, the false negative rate was only 7%. There was 1/4 of patients when the clip was in a non-sentinel node, and that had a higher false negative rate. And quite significant number of patients, that clipped node, so the node that was identified as being positive pre-treatment, was the only positive node, with a very high correlation with final overall lymph node status. So that's led to a number of studies and lots of case series now looking at this concept of targeted axillary dissection. So there's the Mari procedure that's been published out of the Netherlands, the false negative rate 7.1%. There was a cohort published by Cordell et al. From the MD Anderson, and they're showing excellent results. So overall 2%, so 4% if it's just the clipped node. If you're doing SLN and clipped node, it was 1.4%, and then the RISA study, which was 3.5%. So we're seeing very, very good results. This idea that you have the node pre-treatment, you clip that positive node, you remove that node post-therapy. So how do we need to handle these and report them as pathologists? So sometimes you get the clipped node separately, sometimes it comes in a pot. It's usually done as part of a broader axillary node sample or with sentinel nodes. So in my report, I talk about whether or not I've identified the clip site, and sometimes it's in extranodal fat, not in the node itself. I talk about whether or not there's fibrosis in the clipped node and whether or not there's residual tumor in the clipped node. And obviously you also report the other nodes that were received. I must admit I don't routinely do cytokeratins, but if it's negative and there's lots of fibrosis, I've got a very low threshold for doing cytokeratins. We used to do routine levels, and if the node's negative, I would also ask for deeper levels as well, although that's not guidance, that's just what our practice is. So in terms of what's happening management-wise, this is the most recent UK guidelines. So this was from 2023. This is the Association of Breast Surgery, and CN node's normal. The patient has a sentinel node. If they're node negative, no further treatment. And then if they've got micrometastatic disease, including ITCs, they go on to an axillary lymph node dissection, although you could consider axillary radiotherapy. So that's the CN0 group. For CN1 patients, less than 4 abnormal nodes prior to treatment. If the nodes were normalized on ultrasound or MRI, they can have a targeted dissection. But again, in these guidelines, any positive disease, including ITCs, they're recommending axillary clearance. And if the nodes continue to look abnormal, those patients should go straight to axillary node dissection. If more than 4 nodes were abnormal up front, so if they were CN2, all those patients should go to an axillary dissection. Now, this is back in 2023. Our unit has moved on for that, and that's due to evidence, from this study here, the ICARO study. So this is, I guess, more of an audit. It's not a randomized control study, but they got 583 patients, so 62 centers in 18 countries. These were all, 74% were CN plus at diagnosis, And these were patients that had isolated tumour cells in the residual nodes. A third went on to a completion clearance, and these were more likely to have a higher nodal burden at presentation. A third had further positive nodes, 5% with macrometastases. But the point here was the axillary recurrence rate was very, very low, and there was no difference in axillary recurrence rate between the patients that didn't go on to have a clearance and those that had no further surgery. So the recommendation based on their findings was that there's not support for routine axillary lymph node dissection for all patients who have isolated tumour cells post-neoadjuvant chemotherapy. The caveat was the evidence was insufficient in patients that had bulky nodal disease pre-treatment. So that's and the I-SPY trial, again, similar data showing no difference in axillary recurrence rates between axillary lymph node dissection and SLN only. So here's the, and I'd like to thank Eddie Brogy and Stuart Schnitt for helping me find this information, but here's the American Society of Breast Surgeons. So this is their update that was published at the beginning of the year. So what they talk about is SLN for node negative patients. And interestingly, we know in the adjuvant setting, there's now a subset of patients where they're omitting sentinel lymph node completely. They're saying there's currently no evidence for neoadjuvant patients, because it's obviously a higher risk group, to omit sentinel node completely. So upfront image node biopsy if there's clinical suspicion. If it's CN0 and they become clinically node negative post-chemotherapy, either sentinel lymph node with retrieval of 3 or more nodes using a dual mapping approach, because that was the group in the Z1071 that had a less than 10% risk of residual nodal disease, or else TAD with retrieval of the biopsy clipped node. If there's isolated tumour cells, MDT discussion about the need for axillary lymph node dissection, which may be omitted. Again, the patients with more than 4 nodes pre-treatment, current recommendation is for axillary node clearance up front due to the lack of evidence. So indications for axillary lymph node dissection post-chemotherapy, clinically node negative, but where the SLN shows residual micrometastasis or macrometastasis. So ITCs no, micrometastasis or more, they're still advocating axillary lymph node dissection. And there are current trials for role of radiotherapy, particularly the Alliance trial. I believe that's close to recruitment, and we're just awaiting results. And patients who are remain palpably node positive should have a clearance. And if they're CN2 or 3 at presentation, they should have a clearance. And also inflammatory breast cancer always should have an axillary lymph node clearance. This is my final slides. There will be time for questions. This is St. Gallen, and this starts to get really confusing. So ITCs, all subtypes, no further clearance or nodal RT. 1 out of 4 with micrometastasis. ER positive, HER2 negative, no further treatment needed. Triple negative or HER2 positive, consider RT or axillary lymph node dissection. Macrometastases, for the ER positive, HER2 negatives, they're suggesting nodal RT, but for the higher risk groups, they're still suggesting axillary dissection, particularly for the triple negatives. And I think that's my final slide. So I will stop sharing, and hopefully we've got some time for some questions. I'll turn my camera back on.